Thank you very much indeed, Diana, Permanent Secretary. It's a great pleasure to join with you in this important discussion. What a sad time this is. I mean, those figures we've just seen are really shocking, aren't they? If we'd thought where we were going to be a year ago that we're here. So sad for so many people's lives, and I'd like to pay tribute to the health workers in both our countries, who I know have been bearing the sort of brunt of this, but also recognise the real impact on the populations. And those figures about poverty we just heard were terrible, weren't they? I do think it's great that we're having this conversation, and this next session is all about building back better. That's the language we've been using in the UK. It's not just about recovery. It's actually about dealing with some of the problems that have come up and thinking about it in longer and further ways. Really interesting that Lord Popat brought up the issue of global solidarity, really, and how he was talking, and you, Diana, brought up the issue of, you actually said the most important thing for your country in the response was mobilizing the community, the subsidiarity issue, and it is at the two ends of the spectrum, isn't it, that Dr. Jonas has just really described so effectively for us, and fascinating and depressing statistics that he brought forward. So we're going to be talking, and let me just also pay tribute, just as I have the chair for a moment, to Uganda's work on supporting and developing nursing, because I do think part of the solution here is empowering and strengthening nursing long-term in communities and elsewhere. So let me then turn to introduce our three panelists. I don't actually think we've got the first one yet on the screen. If Professor Freddie Sengoba is here, it would be could he make himself known? But I don't think I've seen him yet. Great.
But we could be having the rest of the panelists.
So we'll start with we'll change the order slightly, and we'll go to Neil next. So so we've got a great panelists. We're going to talk about how we continue the progress towards universal health coverage, and I think it is this, not only continue, but that nasty dip on all the graphs that Dr. Jonas showed us. How are we going to recover from that, and indeed accelerate progress towards universal health coverage in countries across the world, I think. So we've got, I hope, Professor Freddie Sengoba from Makerere University School of Public Health. We've certainly got Professor Neil Squires, Director of Global Health for Public Health England, and Professor David Lalu, the Director of the Liverpool School of Tropical Medicine. So I'm going to go to the two of them first, and then come back if we've managed to find Professor Freddie. So let's start off, if we may, Neil, and I think looking at our timing, you've got about 10 minutes or something like that. I hope that was what the organisers said to you. So please take it from there.
Yes, indeed, and thank you. And first of all, I wanted to thank the Minister for the comments that really highlighted the broader context that we do need to address if we're going to deal with this problem. The speech highlighted the need for more investment in promotion and prevention, and that typically is an under-invested area of health systems. And we've learnt that we do need to actively engage, another of the Minister's points, communities, and to empower communities and give them increased confidence. And certainly one of the things that we've seen as a result of COVID is people becoming scared to go to hospitals and use health facilities because of the risk of infection. And one of the consequences of that is that a lot of routine services have been underutilised, and certainly in the UK we're seeing that cancer services, screening services and other things essential for protecting the health of populations are underutilised, and it's important that the dialogue with our communities encourages them to increase. But for every negative, there's potentially a positive, and the increased communication with populations around health risks is incredibly important. And I think we're seeing an increased health literacy amongst populations as people become more familiar with the importance of hygiene and behaviours in terms of health. And we do need, in building back better, to capitalize on that if we're going to sort of, really make the most of this. We've also seen, and in fact, no, I would just refer to WHO's building blocks to really assess, what has happened and how can we build back better. So if we look at service delivery, we heard from Dr. Jonas that service delivery for essential services, malaria, TB, HIV have all been negatively impacted. This is the case across the world with fewer people using services. But the positive side is we've seen innovation in accessing services, which may well have potential benefits. So we've seen a shift to remote service delivery. And things like this may be critically important, particularly in areas which have previously had difficulty in accessing services, given mobile network expansion and other things. So if we can increase people's use of virtual consultations and diagnosis, as we've been seeing in many developed countries, then and we can extend that to more resource poor countries, then potentially we can overcome some of those access challenges which have been a major problem. Moving on to another of the building blocks, that the health workforce. Again, we see the health workforce disproportionately impacted by COVID in terms of the risk that they face every day from infection themselves, and the need to protect our health workforce. That's a critically important message that's been reinforced by the pandemic. If we want to have a quality health workforce, we need to invest in protecting them and supporting them to deliver effective services. And hopefully the learning through this will further increase the respect we all feel for health workers and support them to do their work more effectively. Information systems is another of the important building blocks, and we've seen how important not only sort of testing and sort of diagnosis is in order to help people make decisions about protecting both themselves and their communities, but the importance of conveying that information to the population to increase understanding of risk. So again, we're seeing that we do need to invest in health information systems and in active communication to populations if we want to sort of, tackle not only COVID, but future health problems. And I think there's a lot of positive learning and potentially increased investment in good information systems to improve communication and to increase population understanding of not only COVID risks, but other health risks. And that really is a significant opportunity to build back better. On access to medicines, again, we've seen where we have clinic-based services, potentially access has been limited. Again, there's the potential to move to more online prescribing, but the real challenge is going to come in access to things like the COVID vaccine, for example, where we absolutely do need to ensure that global solidarity ensures that all countries and all vulnerable people have rapid access to potential treatments. And we need to ensure that the vaccine is available and made available in a way that doesn't disrupt other essential services. So we need to protect our routine immunization and use the investments that will be made to distribute COVID to enhance and strengthen essential vaccine distribution. So we've got to look for the opportunities if we want to build back better. On financing, clearly a sort of key building block of the health system, then we are seeing massively increasing investment in health, a recognition that we've underinvested. But also certainly in the UK, we've seen a better and growing understanding of the interface between health and social care, and the need to look at the broader context and the wider determinants of health if we are going to address health emergencies. So hopefully the whole financing of health is increasing our understanding. And again, it was mentioned in the minister's speech that we need health in all policies if we are going to tackle health challenges in future. So the investment considerations need to extend beyond hospital and clinical based services to how do we most appropriately invest to secure the greatest health gain. And that can involve investments in sort of social care or other areas. It also involves one of the key, and the fifth point in the minister's speech, which is the financial risk protection and the need for universal health coverage to ensure that all people are protected from the catastrophic costs of healthcare. So again, important lessons there. And we've seen leadership and the governance of health, the other building block, increasing substantially, and we need to ensure that interest in a dedication to commitment to building health services does help us realise a universal health coverage as we start to build back better. So addressing those key areas of access, where we can begin to explore technology as a route for that, but also exploring the quality of care and the engagement with communities to increase their understanding of their rights to health and the need to ensure appropriate access. So I think, in summary, whilst we've seen the negative impact, the terrible consequences of COVID, we are also beginning to see a better understanding of the need to invest in a broad way if we are going to build back better, to increase access, to protect our health workforce, to utilise the new investments to fill gaps in previous approaches. And hopefully this will strengthen our commitment to universal health coverage as essential and central to global health security, rather than as an afterthought. And my final point really is to make sure that we don't have this immediate moment of panic. I was at a meeting a couple of weeks ago that WHO coordinates on the panic and then forget cycle. We have a moment in time now when there has been a huge impact and there's huge recognition of the dangers that we face. And it's the investment and sustained investment that we now need to mobilise if we are going to build back better and achieve universal health coverage on the back of the investments that will be necessary to recover from the COVID-19 pandemic. And that's all for now, Nigel.
Thank you very much indeed, Neil, and very good to tell us about what's changed and where there are some opportunities. And we've got a choice then, you're telling us, between build back better or panic and then forget. So we can choose which of those strategies we should adopt. Just before I introduce our next speaker, let me just ask people if they'd like to put questions in the Q&A button. There's a Q&A tab at the bottom. We've got one or two questions coming up in the chat. But if you could put your questions in the Q&A, we can make sure that we can get them asked. I'll ask them on your behalf. But with that note, it's my great pleasure then to turn to Professor David Lalou, who is the director and principal, I'm not quite sure of the job title, David, but the boss of the Liverpool School of Hygiene and Liverpool School of Tropical Medicine. So over to you, David.
Thank you. And of course, the challenge of following someone like Neil is that he's made many of the points I wanted to do. And I think I agree with all that Neil has said. I think we've talked already about solidarity. And I do think one element of the solidarity is that suddenly the whole world has realized how interconnected we are around infectious diseases. And that what happens in one country affects another country, even if you're a very high income country like the US, for example. And I think that for me is a really positive step in that I think there will be much more support globally towards supporting universal health coverage and increasing strength of health systems in all sorts of settings, and that people can't just be parochial and focus only on what's happening in their own country. And we've heard what could be thought of as a very gloomy scenario, but I do think it's important to emphasize the positives and as Neil says, pick up the learning. I think in Uganda, for example, we've seen some major initiatives that have been really important. The expansion of oxygen supplies to all hospitals, the putting in of better transport systems and ambulances that have the ability to impact on improved healthcare for many years to come. I think the mobilization of civil society in Uganda around things like hand washing campaigns, again, point the way forward to how we can learn and use more community groups and NGOs in health promotion and health and prevention, those critical issues that have already been identified. And I think also the innovation that Neil touched on, the use of telemedicine, the use of delivery, other modes of deliveries of critical medications, these have been happening in Uganda. And if we can focus on those and move on, there's a potential to really improve health and achieve some of the goals of universal health coverage. I think for me also, the other critical issues focus around access. And we know that access to healthcare has been restricted by various things like travel restrictions, by, I think, the fear of going to hospital, by the concern of communities about accessing healthcare. I think we also need to reflect that even prior to the pandemic, in many countries, the trust of the population in the healthcare system is not that great. Wellcome runs a global monitor report that looks at the population's understanding of science and their trust in the health system. And actually Uganda in that comes out very high, with over 90% of people being interested in science, and with almost 80% very supportive and trusting doctors and nurses. But in that recent survey, and accepting all of the challenges of such surveys, only 54% of people trusted the health system. And I think that's a very important message, that if we really want to improve access and care and get over the issues that will come out of COVID in people not wanting to get to health systems, then we need to think about, as a community, how we improve people's confidence in the healthcare systems. That's highly relevant for vaccines. We've seen concerns about vaccines around the world, and an increasing concerning, I think, concerning move towards a lack of trust in vaccines. And it's really critical that we address those kind of issues with our populations around the world, not just in Uganda, if we really want to achieve better healthcare outcomes. I think there are other challenges. Clearly, there are things like the supply chain, which is been highly disrupted by COVID, and is really critical that we need to think through better and more resilient ways of getting drug supplies to the patients that need them, and control programs, obviously, around HIV, malaria, TB. These are areas which we've achieved enormous success in the last 20-25 years. And it's really important that we don't let those go backwards. And there is some indication, I think, as we saw in the early presentation, that that's starting to change. And we must pay a lot of attention to thinking how we can get those systems back and running as rapidly as possible. The engagement of the community, a point that many people have made, is really critical. And I think mental health is a particular concern of mine at the moment. We've seen evidence around the world of the impact of COVID on mental health. But again, I think this offers an opportunity to think through how we can improve our mental health care services, how we can deliver those, because mental health is a major issue and was a major issue pre-COVID. COVID has brought it into greater highlight, and we just need to think through what it is that we can do, and that may well include things like more remote consultations as we get better technology, how we can really improve the support for people with this huge mental health burden. I think also the critical issue, and this is something that Uganda's had a long history of success in, is the surveillance of infectious diseases. And again, I think we will now see a major recognition from all countries that surveillance of infections in countries that are very remote to their own may well be of huge benefit to the UK public health, for example. And so I would hope that coming out of this, the surveillance and the information systems that Neil talked about will be strengthened and can be strengthened rather more easily than they could be previously. So I think I'll stop there, because I think, as ever, the questions are probably more important than us talking too much, and we'll see what comes out of the questions.
Thank you very much indeed, David, and raising some very important questions around mental health and indeed trust and other issues there. And thank you to people for putting some questions in the Q&A. We've got some great questions that have started to come in there. Now, I'm just going to check again whether we've got Professor Freddie with us or not. I don't think we have. Oh, yes, we do. Oh, yes, we do. I see you've appeared on my screen, Professor Freddie Sengoba. Can I turn to you now to unmute yourself, which I see you've done, and put yourself on video and give us your presentation. Thank you very much.
Clearly, I'm glad to join you and to discuss this topic today on deliberations about how we can put back or at least continue on the roadmap for UHC in the context of the pandemic. I come from the perspective of working very closely within the perspective of serving on the scientific committee of the Ministry of Health, especially around COVID and giving guidance on that. But also I had opportunity to work on universal health coverage agenda for Uganda for the last 5 years, and been leading on the roadmap for UHC currently that government is using to develop the sector plan for the next 5 years. So from those insights, I think a couple of things stand out, which are important for us to reflect on. How do we get better on this road? I think one of the opportunities I can say lies within the fact that as a country, we had taken a number of efforts over the years to try and beef up a number of capabilities, and this is going to continue to be useful to build upon. But one of the capabilities I can speak about has been about building the base for human resource and competencies around managing disease outbreaks. With our partners, the country has established laboratories, has trained many epidemiologists, and many of our district leaders have been in many ways trained and oriented on the management of outbreaks. Uganda also have had its share of this in the past. So many of these processes have been rehearsed in some way. So of course that gave us a starting point around which to respond to the pandemic. Other factors notwithstanding, I think that the country and the leadership has played an important role in trying to ensure that we stay on a scientific-led approach, especially for the pandemic, but also to ensure that the pandemic doesn't derail the activities of the sector in terms of addressing other healthcare needs. So those, I think, are good starting points, but there are also challenges that we see that the pandemic has brought about. The major one is the whole issue of using evidence-based control to the COVID-19. I think we have, like many countries, actually failed to understand clearly where we are in the epidemic, given that testing is very hard to use to understand where we are. And all countries, including us, have suffered the issue of is the testing really based on where the epidemic is or where the testing capacity can take us? And that remains to be a challenge. Again, that we have had a problem with the testing. It remains to be a challenge in terms of its availability, but also its deployment to tell us the issue of where the epidemic is or where the testing capacity lies. So right now, when capacity is available, we see more people testing. When this is not adequate, we don't know whether the epidemic has disappeared or is just going undiagnosed. It is also very costly. I think Uganda has spent over, from the last time I saw, more than 30 million just trying to deploy tests. The tests remain very expensive. It's not very clear whether that is the cost of these technologies or it is just that opportunities have opened for people to make some money. So the whole issue of technologies for COVID, but also for the upcoming vaccines remain a challenge. I believe I missed many of the discussions other people raised, but the hopefulness of vaccines for us to get out of this environment remains remote for countries like Uganda, partly because these resources don't easily get distributed fast enough for countries like Uganda to really use them as the potential intervention to really manage the epidemic. And we are now at a stage where we are trying to debate whether the vaccines are going to be essential variable or is it after 2 years, after 3 years? And if schools are to start and the policymakers are thinking the the vaccines will help, we're not too sure that will be available in big quantities or affordable to us in the short term. But clearly, human rights approach is being used. I'm not sure how effective it can bring about vaccines globally. Usually, vaccines have helped us because we are usually few that are handling epidemics. So the whole distributional demand is not that high. But right now, I think it is too high for countries like ours to have effective way to secure enough to get us going. But as I finalize, I think we are beginning to see more use of routine services coming back, and that is critical. But in doing so, we also are beginning to worry about the vulnerability of health workers to COVID and potentially them being the vector to kind of infect patients or their families. And this is a big area of vulnerability to UHC going forward. So we think that for these 2-3 years, WHO says COVID is here to stay. I'm not sure how true that is. But for the period for which COVID is available, I think we also are planning to see how we can make our health system more robust, health workers protected, but also communities better informed. The biggest challenge I see in Africa and in Uganda and probably globally is that the communities are beginning to walk away from the whole response. You could call it fatigue about COVID, and sometimes that creates more flare-ups of epidemic elsewhere. So as we move into the trying to boost up the routine services and to ensure that we work on the broadest platform of providing all services, I think this remains a key issue. And lastly is the additional costs that we are trying to put across for PPEs, for all of these guidelines which are going, they are increasing, of course, the cost of services to the public, to the private sector, and governments around the world, including Uganda, need to really hammer out a way to embrace a collaboration with private sector actors. I've seen countries trying to go to open up a stadium and put beds there when the private sector have beds that would potentially be useful, but they are not engaging them partly because they fear that they will be charging them a little more money. I think this issue of how do we collaborate in a situation of epidemics is going to be very important for governments to rebalance their concerns for using public sector predominantly for COVID and working with others. Because if we don't expand the platform, the chances are we'll be opening up additional capabilities that cannot be effective. And yet those that are effective are not really being embraced. If we are able to address that, I believe we'll be able to mitigate the impact on UHC by COVID. Thank you very much, Chair. I'll stop here for now.
Thank you very much indeed, Freddie. Very good to have you with us, even if we can't see you, and very helpful points that you're making. We're now getting on to question and answers. We've got about 20 minutes, and we've got 11 questions that I can see at the moment. And the one I want to start off with is quite appropriate to our discussion just now, as it were, which is internet connection. Both Charlotte Hardy and Linda Shuttleworth have raised the issue of internet coverage and the ability to do things like well, this sort of conference, but actually teleconsultations and so on, and how important that is. And the question that Charlotte puts in particular is if I just find it precisely, is there a plan to invest in better Wi-Fi and data coverage and try to make it more available to the least advantaged? Can I turn to Professor Freddie for that first of all, and then come to Neil and David for an external perception of what maybe the partners can do around this. But starting with you, Freddie, is there a plan?
Thank you, thank you. I'm glad you start with me because it's taken me almost about 40 minutes to get the connection for this call. Apparently, we have since March worked very much with data and trying to ensure that the internet becomes the new ways that we can meet through Zoom and related other platforms that have come up. But the more that we have embraced IT, we've seen that those who are providing especially data services in a part of the world have become more, I don't know, I don't know whether to use the word. They've not been very cooperative in terms of costs of bundles and bandwidth. Actually now, since March, I think the cost of the data bundle that I usually use for a month has more than doubled. And that tells you that we are not really all working with the understanding that these are unique times, and we really needed to see how to help each other. As more people use data, the companies have not been very able to try to lower prices. And I think this also speaks to the broader issue. How do these new ways of doing things become affordable, or otherwise, if they become too costly, it also creates more challenges than being able to enable us. But clearly, it's been a major source, internet, it's been a major source of continuity for schools, for education. It's I can't speak well to the issue of how it is being used for clinical consultation, but there is a lot of doctors who now work off the phone or internet instead of seeing patients directly. I'll stop here. Thank you.
You're on mute, Nigel.
Yeah, no, I've come off. Before you go, actually, Freddie, can I just ask you, there are two other questions, well, actually not questions, they come up in the chat, where people are saying things, there are things you can do, training, for example. There's somebody here, I can't actually see who it is, but in the Infectious Disease Institute at Makerere uses two methods of training which are light on the internet, interactive voice response training, and interactive case studies that can be downloaded as a PDF for offline learning. And somebody else was referring to something quite similar, I think, that was used to store data so that you don't have to do it live. Are those things that you think are worth exploring? And then I'll come to my other colleagues.
Yes, the short answer is yes. And actually, some of them have been in practice before. At our school, we have even a whole master's program that is run on a distance, trying to train those people who are in service who don't have time to go and come to the university to study. And we've, in the past, of course, given them hard copies. Eventually, we moved to these CD-ROMs and data that they take, with, of course, some online sessions that are discussional and a bit of assignments. So we, of course, now moved when more data became available for those that are pro-urban to even do Zoom lectures. But today I even heard from the news, the government is going back to producing these kind of tapes and CDs that could be written and distributed so people have access to materials, and then through radio can have guidance. So I think countries are having different approaches to it, but I think the level of technology is moving forward and backwards depending on how the scale. The scale right now is too big to use interactive training. But as you said, all these models are available. it depends very much the audience you're dealing with, if they are able to have interactiveness that is happening. Otherwise, when you're dealing with very remote without reliable connection, we are trying to use the technologies of some Easter years a bit. Thank you.
Thank you very much for that. Let me now turn to Neil and David in turn, because this seems to me to be a really important point, and perhaps addressing the point what we should be doing from outside Uganda to support that. Not that our internet coverage is always perfect in the UK, let's be clear. But Neil, do you want to go first?
Well, I mean, I think this is such an important issue, but it goes way beyond health. I mean, obviously, internet and mobile access are critical for economic development generally. So it absolutely has to be part of a national strategy to increase coverage, and health will benefit from that, but the economies more broadly will benefit. Certainly, I think we've seen mobile penetration across Africa has been greater than internet penetration, and that's likely to continue. And I know WHO certainly was doing a lot on sort of, packaging health interventions for mobile disbursement and linking to health workers. And I think that whole area of work is something that does need to be expanded. But in terms of the major structural investments, I mean, sort of, I'd lost touch with the progress that was being made on these Trans-Africa submarine cable to increase certainly access to countries with coastal access, but an absolute priority for investment, and we can see now how important it is. But maintaining children's education, for example, in remote areas and enhancing it through internet access makes education equally an important area for investment in access to this technology. So something that should be prioritized.
Yeah, no, thanks for that. Interestingly, there's quite a few people putting in their views on the chat, so I suggest people might look at that for some really interesting examples. But David, do you want to add anything on this?
I think just a couple of points. I think clearly it is an area that's very important to invest in, but I do think it's also really important to recognize that kind of approach of telemedicine, it will always only be part of an offering. And I think it's really important that we don't distort the health sector too much towards overinvestment in technology, because what concerns me about that is that I think that means that the hard to reach populations and the marginalized populations will become even more disadvantaged. So for me, that this has to be very much and I think a bit as Freddie said, there has to be a mixed approach. There has to be investment where it's appropriate. It mustn't distort things. We should use, I think, and Ross, the comment I think from IDI was from Ross Parks-Watanshi, who's on the panel later on, so maybe she can talk about that a bit more. But we have to use the analog phones, and we don't know the things that don't depend on smartphones as a package. But we must be very, very careful that we don't distort access in this way.
Yeah, really important point that you're making there, and one or two other people in the chat box are making the same point. That doesn't mean to say we shouldn't be doing it, but it's not a silver bullet, to use that sort of language. I do notice there's another one, and David, I'll come to you first on this, I think, because it sort of follows on from Simon Segura, who talks about human resources for health, which I'm not going to try and cover in this session because that's the next session chaired by Francis Amazwa. But medical products and technologies have a direct and disproportionate effect on health service delivery. And could you say anything, if you know it, what strategies are currently under consideration by international health partners to support national governments in view of financial challenges? Where do we see and how optimistic are we about financial support and for these areas? I don't know, David, if you can.
Well, I can take that in a general sense. I think we have to be currently, and I'll talk from a UK focus initially. I think at this stage in the UK, I don't think we fully understand what the implications of COVID will be on the aid budget and the strong political commitment of 0.7% of GNI to overseas development, I think, continues. But of course, that will be 0.7% likely of a reduced GNI. And I don't think we have any idea yet what the real consequences will be. but I am certainly concerned that the availability of finance for aid overseas will be reduced, not just from the UK, but from every high-income country, and not just for a year or so, potentially, if you look at economic projections, for the next 5 years. And so that is a genuine and I think a general concern that many of us in development have at the moment. It's just very difficult to predict where we will be. The more specific question about how that financing is applied, I think actually ultimately, and certainly the UK principle has been very much that's heavily driven by the desire of the governments that the UK is working with. And so I think in terms of prioritization, that's actually a matter for the Uganda government and the Ministry of Health, rather than for a UK funding organisation to impose that.
Yeah, thank you for that. I'm going to go to Neil, and then I'll ask Freddie if he wants to say something on this. I also just wondered whether Dr. Jonas was still with us and whether he could say something from the WHO point of view on this question of finance. But Neil, would you like to just make a comment on finance?
Yeah, well, some of the initiatives such as COVAX, for example, which is the coordination of funding for vaccine access, which is being developed jointly with the Africa Union, and does require that solidarity, that collaboration between the countries of Africa in order to ensure access to the market. It's much better for some of these large-scale procurements that countries collaborate with each other in order to get the best possible price. But also we've seen with access to antiretrovirals, there is an absolute need to negotiate on price and ensure that it is accessible and affordable. And I think some of those mechanisms around global funds that have previously been created will at least help ensure the market pressure to minimize the price is maintained, and these things which are about collaboration and solidarity remain vitally important mechanisms.
Yeah, thank you very much. Freddie, would you like to say something on this point about the need for finance, but also the specifics of how that might be available? And nice to see you. Now.
Thank you. I have to say, yeah, I'm in a slightly secure place now in terms of data. I've been moving from various
right, very
connections. Good. So yes, thank you. About financing and how do we go about, I think one of the opportunities that COVID has brought about, which I think is also need to be recognized, is the need for domestic resource allocation and also to mobilize what I call private citizens to contribute. We've seen contributions from the public that we never thought would be possible. And I think those should be still remain open, especially for interventions like vaccines when they eventually become available in terms of supply. But also for our colleagues, especially in the finance, I think now the demand, or at least the understanding of the health security issues around become very clear, at least in this sense. We do not expect to see major leaps in a domestic budget allocation, but we think we have a very good will and a basis on which to actually make a claim. I also needed to use this opportunity to really appreciate. I think if you look at how we've managed, I think the COVID area since March, we've really received a lot of support from our partners, some of them bilateral partners, including US government, UK governments, and of course, including small collaboration like lab-to-lab collaboration to share reagents. At some point, this sustained us for almost 3 months, trying to get some tests because the procurement processes were difficult. So I think what to say that, yes, we needed to continue to lobby for more support within the national budgets, especially to try and deal with these extra needs. But one of the issues we should not forget is how to negotiate collectively. I think that point has been made. So that these prices can be manageable, or at least we do not necessarily divert all the resources into one area and then start having those issues, including maternal health and child health, suffering because of the diversions which might come because of trying to deal with the issue. I think these are the balancing act that we expect, especially when it comes to financing, but also the issue of cost management. Thank you.
Thank you very much, Freddie. Could we turn to Dr. Jonas, and would you like to give us a view from where you sit of Africa, I guess, and not just Uganda, in terms of this big issue of finance, and how you're seeing what the future may look like around this, and what you'd like to see?
Yeah, as I was saying, I think what this pandemic has taught us is the benefit of the solidarity. Basically, just as an example, the test kits which are sold to the consortium at $20 are literally about $70, $80 in the normal market. I think there is a lot of goodwill from this pandemic, but this is a reaction for an emergency. How do we channel this solidarity, this understanding, this caring for our neighbors and understanding the common good to the rest of the health? Now we see, I mean, all donors have increased significantly their contribution for example, the vaccine development, which would benefit also developing world. But will that continue? I think that's the whole point. And from countries, developing countries like ours, what we have to look into is also what are the efficiency saving we can do? What are the things which we need to do in terms of prevention? What is that we learn from this pandemic, the fact that masks, hand washing, physical distancing, which may not cost as much as the vaccine and the drugs and so forth, are actually understood by the community. Where did we get, how do we get the community's engagement would have a very big bearing on how much the health services would cost. Because one thing we can learn from here is we may be able to do things at a relatively affordable amount, including investing in technologies which will benefit the health and the global health in general. So, but yes, when you lose $30 trillion in 2 years, where do we get it? It's just a simple, the development assistance will decrease, other investments will decrease, but how do we use especially funds mobilized locally and national resources efficiently will be a major part of how this would resolve in a way. Thank you.
Thank you very much. There's actually 2 or 3 questions on mental health, and one of them is directed very definitely at the Permanent Secretary, and I wonder if Diana is still on the line and able to take the question on that. But just while I give her advance warning of that, if she's still here, I want to pick up that last point just personally about the point that Dr. Jonas just made about, in a sense, mobilizing the community. My good friend Francis Omazwa has a saying, "Health is made at home, hospitals are for repairs." And I wrote a book about it, thank you, Francis. But the important point there, as much as anything else, is health is made at home, created at home, and healthy communities and healthy societies support health in all kinds of different ways. And I do think this is really an important point for us here in tackling the whole COVID epidemic. But let's pick up on mental health, and then the final topic I'll try and touch on is self-care and the role of the community. But mental health, is Diana still with us? I think she may not be. In which case, can I turn the question on mental health to the other panelists? David, you actually raised mental health, didn't you? What are your thoughts about what countries should be doing? Not just because, as one of the questions says, mental hospitals or beds for people with mental health problems have been repurposed for COVID, and therefore people are being moved out into other facilities or not giving care. So in terms of the care aspect, but also the other aspect, which is we're all worried, aren't we? And that can tip over into anxiousness and into clinical symptoms in terms of what COVID is doing to us all, I think. So David, would you like some thoughts on that?
So I think there's two bits to that, and I'll take the second one first. I think the general anxiety, the concerns that everyone has at the moment are real. But I do think that what governments and health organizations do there is make sure that as much information is getting out to people as possible. That reassurance to individuals about what's being done, the steps that countries are taking, what the plans are, so that people are much more as aware as possible of what's going on, I think is really helpful, because some of that anxiety comes from a lack of knowing or understanding where things are and where you're going. And obviously we accept that the future is uncertain, but if you can inform people as much and make it very clear what's expected of them, I think you can reduce some of that general anxiety. If we take your first question, then the challenges of mental health in settings like Uganda are definitely not new, and I think they certainly have been under-recognized by the development community, and certainly underfunded by the development community, and for some time. And I think we have started to see in the last 10 years a huge recognition that we need to put more funding into mental health, train more psychiatrists, train more psychiatric nurses. I think fundamentally that's what has to continue. It has to be that investment and recognition of the enormous burden of unmet mental health care needs that are out there at the moment, that will only be increased by COVID. I'm afraid I don't have any magic solutions or magic bullets for that, and if I did, I think many countries would have adopted those. It simply has to be higher on the agenda, and there has to be a higher proportion of resources go towards it.
Thank you very much indeed, David. I'm going to now turn to Neil. And Neil, would you like to say a quick word on mental health, but also just on the role of communities? And just a quick word again. And then I'm going to turn to Freddie for the last word before actually I have a final last word just to wrap up the session. And we've got about 3 minutes. So Neil.
Yeah, well, I linking the two together. I mean, I think the opportunity that comes with COVID is the dialogue with communities, and I think destigmatizing mental health as an issue that we can and should all be talking about is probably one of the most important things that we could do. And I mentioned previously health literacy and the opportunities to communicate effectively with communities on health issues beyond COVID. We should make the most of this time and this engagement and this investment that we're making to increase that dialogue with communities, extend it beyond hand washing into mental health issues and other aspects of the response, and yeah, really make the most of this opportunity to increase health literacy.
Great, thank you very much. Freddie.
Thank you. I think definitely my comment will be the same. We really need to engage communities and those who have the struggle, amplify the messages and to help communities learn. I think the challenge we've seen in COVID is that the facts and the behaviors we expect of communities can be very hard to communicate. They change a lot. And sometimes they've created a wedge between the scientists and the technical people and the community and the media, partly because of this pandemic. But it's important to also invest in that process of sense making. How can we help to hear voices of communities? Because it is their behavior that quite importantly make a difference, especially what they choose to do or not to do. But how do we help them to quickly be able to adjust and if, for example, we find now it's wearing masks that is important, be able to make sure that they do those. If it is gatherings that we need to ensure we do not join without, especially where sort of or distancing ourselves. So these are all very important, but I must say that we do not have very engaging programs that quickly can make communities work with us this journey. I think at the shock element, when the pandemic had just come, they were much willing. Right now, we really need to do more to ensure they are engaged and they continue to make sense of the new guidelines they need to take on board, and there also requires engagement. Thank you very much.
Thank you very much indeed. And so it just remains for me to just say thank you to the panelists. I think that's been a really interesting discussion, the way people have brought in different ideas and different thoughts. A really good set of ideas coming out there, including this point that there are opportunities and that we should build back better and not just build back, but also this notion of subsidiarity at one level, but also solidarity at the other. And these issues apply in the UK just as much as they do in Uganda in different ways. We can all learn from each other around this. I'm looking forward to hearing a bit later on from Francis Omazwa, who will pick up some of these themes, I'm sure, and pick up the human resources ones that we haven't got to during this discussion. But I would also suggest people might want to look in the chat because there's lots of interesting stuff coming up there. And at that point, I'm going to hand it back to the organisers. So thank you all very much.